students, welcome to today's session. In today's session, we'll be discussing endocrine disorders in children. So beginning with the pituitary disorders, first we'll do the short stature. Short stature, the most common cause is the growth hormone deficiency, which is the dwarfism. Most common cause because of primary growth hormone deficiency, where the growth hormone genes itself are not expressed. Another situation is where the growth hormone releasing hormone receptor deficiencies are present. So because of that, the receptor is. Acquired cause of growth hormone deficiency are radiotherapy, meningitis, histiocytosis, and head injury or trauma. Clinical features, the craniofacies of growth hormone deficiency are: you have a childlike convexity of face. You have retrognathia. And increased growth of posterior facial length than anterior. You also have a smaller mandible. These are the features of dwarfism or craniofacial features of dwarfism. Once you have therapy with growth hormone therapy, this can result in prognathism, elongation of the face, widening of the face, formation of the increased width of the nasolabial furrow. All this is possible. There is also delayed growth and development of the child. Now, this delayed development is plus minus. We have seen some children with dwarfism who have delayed achievement of milestones, and I have seen some dwarfism children who also have normal attainment of milestones. Micropenis, osteopenia also occur. Diagnosis is done by the growth hormone stimulation test, where the cutoff is less than 10 nanogram per ml, where you will try to stimulate the growth hormone, and after stimulating, if your level in the blood is going to be less than 10 nanogram per ml, it is diagnostic. Along with measurement of growth hormone, you also be measuring the insulin-like growth factor 1 binding protein levels. Treatment is by recombinant growth hormone supplementation with subcutaneous injection. It does have side effects of gynecomastia, impaired glucose tolerance, and pseudotumor cerebri. Now coming to thyroid disorders, most common congenital hypothyroidism. The incidence of congenital hypothyroidism worldwide is 1 in 3,000 infants, which is a very high incidence. It's supposed to be more common in girls. There are two primary causes, primary and secondary. Primary is where the problem lies in the thyroid. Secondary is where the problem lies centrally in the pituitary. This is what you must remember. Always we tend to get confused. We think primary is somewhere here, secondary is somewhere there. No. Primary is where the primary organ is. Secondary is where what stimulates that organ gets affected. So thyroid dysgenesis, thyroid dishormonogenesis, defect in thyroid hormone transport because of the MCT8 gene defect, and maternal thyrotropin receptor blocking antibodies are present in the blood. Central or the pituitary induced hypothyroidism, thyroid releasing hormone deficiency, and thyroid releasing hormone unresponsiveness. What are the clinical features? You have patent posterior fontanelle with wide open cranial sutures with a normal head circumference. Remember, this you will see even in hydrocephalus. What's the difference? In hydrocephalus you have macrocephaly. Here you have normal head circumference. Umbilical hernia, constipation, hypothermia, prolonged physiological jaundice and hypotonia, Kocher-Debre-Semelaigne syndrome. Now this is, you see it in older children. All this you can see it in smaller children as well. You have cold intolerance, delayed development, sleepy and lethargic child. Sleepy, lethargic child, delayed dentition. Now, what is the Kocher-Debre-Semelaigne syndrome? This is calf muscle hypertrophy. Here you have calf muscle hypertrophy, but however it regresses with treatment. Diagnosis, now remember, you have the thyroid releasing hormone, thyroid stimulating hormone, and the T3 and T4, the primary thyroid hormones. If you have TSH elevated and T3 and T4 low, that is primary hypothyroidism. Primary hypothyroidism. If you have TSH low, T3, T4 also low, it is secondary or central hypothyroidism. The ECG shows low voltage P and T waves with diminished amplitude of QRS complexes. EEG also shows low voltage complexes. Serum cholesterol, sometimes if you do, you may find elevated in children less than 2 years of age. So if you have this, you have poor ventricular functioning with pericardial effusion. That is why when you have this low voltage PT waves, diminished QRS complexes, you must be careful. What are the X-ray changes of congenital hypothyroidism? Absence of femoral epiphysis at birth, punctuate epiphyseal dysgenesis, beaking of the vertebrae, especially T12, L1 and L2. Skull X-ray shows large fontanelle, wild sutures and Wormian bones. Treatment, the dose is what is important. Oral thyroxine supplementation is very important. Higher dose in newborns, 10 to 15 microgram per kg per day. In older children, comes to 4 to 8 microgram per kg per day. Every third monthly, you will monitor the thyroid function test, watch the growth, watch the development and adjust the thyroxine dosing. Coming to cretinism. What is cretinism? Cretinism is a condition of severely stunted physical and mental growth due to untreated congenital hypothyroidism or from prolonged nutritional deficiency of iodine. Endemic cretinism is due to nutritional deficiency of iodine. Sporadic is primarily because of congenital hypothyroidism. Cretin has all the features of congenital hypothyroidism with a significant amount of mental retardation. Coming to adrenal disorders. First, the most important, congenital adrenal hyperplasia. The inheritance of this is autosomal recessive, which is very important. Here you have a defect in the cortisol deficiency. So when you have defect because resulting in cortisol deficiency, there is increased secretion of corticotropin or the ACTH hormone. Because of that, you have adrenocortical hyperplasia and overproduction of the metabolites just prior to where the enzyme is deficient. 4 main enzymes are involved in congenital hyperplasia pathophysiology. Most common, the 21 hydroxylase deficiency. Second, 11 beta hydroxylase deficiency. Then the 3 beta hydroxyl steroid dehydrogenase deficiency. And the 17 hydroxylase deficiency. Now, this is the pathway which you all know and you should know, where cholesterol becomes pregnenolone. Here you have the common as 17 alpha hydroxylase deficiency. So none of the pathways from here will happen. Automatically more of aldosterone, corticosterone gets produced. The others are the 21 hydroxylase, which is the commonest here. So none of the corticosterone, aldosterone get produced. Automatically you have more of cortisol and testosterone which gets produced. So here, so in the 21 hydroxylase deficiency, you do not have any of the aldosterone and cortisol being produced. So the entire pathway gets diverted from progesterone and goes into the testosterone pathway. Similarly, in the 11 beta hydroxylase also, you cannot produce from corticosterone, aldosterone, and cortisol. The immediate pre-metabolites and the testosterone pathway get stimulated. Now, diagnosis of this is by the 17 hydroxy progesterone levels you will do, and that will help you tell you whether the enzyme is deficient at which level. So with the 17 hydroxy progesterone levels, you can do ultrasound or MRI to demonstrate the congenital adrenal hyperplasia. Now remember, how do you suspect is very important. So a neonate with vomiting, dehydration, features of shock is where you must suspect congenital adrenal hyperplasia. These children will have low sodium, high potassium levels because the aldosterone hormone is not there, and you will have ambiguous genitalia. These ambiguous genitalia are more common in female children, especially when there is virilization because of the testosterone pathway being stimulated. How do you treat? Treatment is the replacement of the glucocorticoid and mineralocorticoid. Glucocorticoid replacement is with hydrocortisone. 15 to 20 mg per meter square per day. Remember, It is not per kg, per meter square per day. And the fludrocortisone is the mineralocorticoid replacement. Initially, if the ambiguous genital is very significant, you will have to do a karyotype to confirm the genitals of the child, and then once the genetics, the karyotype has come, you can decide whether it's a male or female child. Later on, we have to plan surgery for the ambiguous genitalia. Prenatal treatment, yes, in the OBG side, there is a prenatal treatment where they say that giving dexamethasone 20 microgram per kg does help to prevent congenital hyperplasia, but that's not a standard mode of treatment. Now remember, whatever the congenital hyperplasia, it's very important for good follow-up with patient education is very, very important. Coming to diabetes mellitus, two types, type 1 insulin dependent and type 2 insulin resistant. And then you have genetic defects of beta cell functions where the diabetes occurs very early, or MODY, which is the maturity onset diabetes mellitus of the young. That is MODY. You have MODY 1, 2, 3, 4, 5. And you have other causes. We have seen that a very significant pancreatitis, viral infections of the pancreas can also produce short-term diabetes. Drug-induced, we have seen tacrolimus, mycophenolate mofetil, these drugs given in bone marrow transplant children can also trigger diabetes. Now, what are the different types of diabetes and how do they vary? The classical type 1 diabetes presents at 5 to 7 years with the second peak at puberty. Type 2 is primarily pubertal, and MODY can present somewhere in the adolescence to up to 25 years of age. Onset is classical features. You'll have polyuria, polydipsia, polyphagia, and commonly present in DKA. Type 1 is the IDDM. So it presents with usually DKA. Type 2 is usually insidious in presentation, like the MODY. Pathogenesis. Type 1 is the autoimmune destruction of the beta cells. Type 2 is insulin resistance. So actually these children have more insulin and the periphery resistance is present. And MODY is present because of genetic defects. Treatment IDDM, insulin deficiency, supplement with insulin, long-acting and short-acting. Type 2, first line is metformin to improve the insulin sensitivity. Second line is sulfonylureas. In MODY, you have MODY 1 to 4 sulfonylureas, whereas MODY 5, there is no option, it's only insulin. Diagnostic criteria are when you have symptoms with a plasma random of more than 200, or fasting plasma more than 126, or an oral glucose tolerance test more than 200, with HbA1c more than 6.5. This is how you diagnose diabetes mellitus. Treatment of choice insulin. Rapidly acting insulin lispro, insulin aspart, and insulin glulicin. Intermediate acting are the neutral protamine Hague-Down insulin, lente insulin. Long acting are the insulin glargine. Now always with regular GRBS monitoring pre-post meal plus titrating the insulin dosing. So the insulin dosing has to be titrated based upon the pre-meal GRBS. Now remember, with the pre-meal GRBS, it is the previous insulin which needs to be titrated and not the insulin. You're not giving insulin as treatment. You're going to see what is causing the GRBS to become that level and titrate accordingly. Now, what are the acute complications and chronic complications? Acute complications is DKA as well as non-ketotic hyperosmolar coma, which produces cerebral edema. Chronic complications where you have microvascular retinopathy, macular edema, neuropathy, peripheral neuropathy, macrovascular complications of coronary heart disease, cerebral vascular disease, peripheral arterial disease, gastroparesis, diarrhea, susceptibility to infections, cataracts, glaucoma are the chronic complications of diabetes. Coming to disorders of puberty. Disorders of puberty are of two types. You have precocious puberty and you have delayed puberty. Precocious puberty is defined by the onset of secondary sexual characters before the age of 8 years in girls, that's important, and before the age of 9 years in boys. They are of two types, the central precocity where the problem is in the pituitary and the peripheral precocity where the problem is in the gonads. Central precocious puberty is the most common type. It's gonadotropin dependent. Girls are affected more than boys. In girls, it's primarily idiopathic. In boys, you have to look out for CNS pathology. Treatment of GnRS analogs, typically leuprolide acetate. is the drug of choice. Now, why are we using GnRH agonist? To cause the feedback inhibition. Peripheral precocious puberty, you have two types. You have isosexual and heterosexual. Isosexual is where the same sex is what is expressed. Heterosexual is where you have virilization. This is gonadotropin independent or pseudo puberty. Here, boys are affected more than girls. Cause is primarily congenital adrenal hyperplasia. In girls, it's ovarian cause. Treatment is treatment of the cause. Coming to delayed puberty, in boys, if there is no increase or no appearance of secondary sexual characters, as evidenced by increase in the volume of the testis by 14 years. Or in girls, absence of breast bud by 13 years or menarche by 16 years or within 5 years of puberty onset. This is supposed to be definition for delayed puberty. Delayed puberty is more common in boys than in girls. Constitutional delay is the most common cause. Chronic systemic diseases like gluten enteropathy, anorexia nervosa are the causes. Now you have two types where you have hypogonadotropic hypogonadism. The problem is again here. So you have low FSH and LH. Problem is in the CNS. Hypopituitarism and syndromes with gonadotropin deficiency. Hypogonadotropic hypogonadism. Hypergonadotropic hypogonadism is the CNS is normal, producing excessive amount of gonadotropins, and the gonads are not responding to that. So you have high FSH and LH. You have gonadal disorders and syndromes like Turner's, Noonan and Klinefelter syndrome. Now coming to obesity. Obesity is excessive fat deposition in the body to the extent that health can be impaired. There is excessive caloric intake associated with decreased energy expenditure, which results in excessive calorie retention and obesity. Now the cause of obesity can be endocrine as well, where you have hypothyroidism, Cushing syndrome or growth hormone deficiency. Hypothalamic causes like head injury, infection in the central nervous system, brain tumors, radiation, post-neurosurgery or any trauma or surgery in the brain, drugs like corticosteroids and valproate. Diagnosis, always you must diagnose with BMI and plot on charts. Remember, in adults you can use this above 23, above 25, above 28, above 30. This criteria you can use only in adults. In children, the growth charts have to be plotted because the BMI varies for different ages of the child. Other parameters are skin fold thickness, the waist circumference, the waist to hip ratio. You have density based methods like densitometry or the underwater weighing. Here the fat is lighter than the body mass. So based upon that, densitometry helps to identify how much of the fat mass is there in the body versus how much of the lean muscle mass. Scanning methods. The scanning methods are the CT and the MRI. This helps to find out the fats within which are around the internal body organs as well as the lean body mass, etc. based upon scanning. You also have the bioelectric impedance methods which are used to assess exactly how much is the fat in the body. Now using growth charts, this is very important, growth charts. Underweight is less than 5th centile. Between 5th and 85th centile is normal. Overweight is between 85th and 95th. And obesity is above the 95th centile. Important management techniques are lifestyle modification, where you have diet and exercise. Remember, the exercise should be the exercise the child likes to do and not forced exercise. The child, whatever he or she enjoys, that's the exercise you must plan for. We cannot cut diet very strictly in children. Always try to replace the diet with equally interesting healthy alternatives. Bariatric surgery is done only when the obesity affects the lifestyle of the child. It is done as a late measure, not done initially. I am yet to see a child who has undergone bariatric techniques. Pharmacotherapy also not commonly used in children, but yes, the drugs which can be used are orlistat. Commonly what we use is metformin, because where we see obesity in children is the metabolic syndrome. So for that, metformin really helps. These children, especially the girls, also have PCOD. So metformin is useful. Sibutramine. But remember, pharmacotherapy is only last choice. We use metformin when the child is trying his best. Obesity is very significant and you want to bring down the weight around to a healthy weight as fast as possible. Short course metformin is used and this is stopped once the child reaches the healthy weight parameters. So with this, we'll be concluding this session on endocrine disorders of childhood. Thank you.